Thank you everyone for having me to the NAMI public information talk for this month. My name's Davin Quinn. I'm a psychiatrist at the University of New Mexico Hospital. I'm an associate professor in psychiatry, and my area of focus and interest and actually research is in non-invasive brain stimulation for various disorders, psychiatric disorders. So I'm very pleased to be here tonight to speak with you about transcranial magnetic stimulation, some of the theory behind TMS for short, and how it works, some of the evidence for its effectiveness in major depressive disorder, which is a very, very common problem. And then I'll also be pleased to tell you about some of the studies that we have going on at UNM currently. And I'm happy to take any questions along the way. Tom, should we wait till the end for questions and just sort of get through the slides?
What we normally try to do, if somebody is confused or doesn't understand what you said, they're welcome to ask questions during the talk. And then substantive questions we try to hold to the end. It doesn't always work, but that's what we try.
Perfect. Okay. We'll just interrupt or raise your hand if there's something that I need to address. Can you all see my slides there?
Yes.
Yes.
Thank you. So again, this talk is on the theory and practice of transcranial magnetic stimulation for major depression. And we'll cover three main topics. What is repetitive transcranial magnetic stimulation, or RTMS for short? How safe and effective is it for major depression? How does it work? And then tell you about our service's experience over the past 3 years since we first set up this clinical service. So I'd just like to start with a case presentation. This is a composite patient who, this is meant to represent the very typical kind of referral that we receive for someone who can be treated with transcranial magnetic stimulation. So we very often get patients like this, and this is the kind of patient who would do well with transcranial magnetic stimulation. So for instance, a 50-year-old female who's had chronic major depressive disorder since early adulthood. Most patients of ours come and say that they've had depression for decades. They often have a history of physical abuse in childhood, like this patient, hospitalization in early adulthood after a suicide attempt. So really significant depression that has been very disruptive to their lives. This patient also is recently diagnosed with comorbid PTSD or post-traumatic stress disorder. More often than not, we see people having multiple disorders, more than just major depression, often an anxiety disorder, as well as any medical conditions that they may have. And this person's chronic symptoms are very consistent with the typical symptoms of depression: low mood, anhedonia or inability to enjoy anything, guilt and low self-esteem, low motivation, difficulty focusing, and low energy. The common theme across our patients is that they've tried multiple treatments, medications, psychotherapy, even they may have tried other forms of brain stimulation, and nothing has seemed to work for them. This patient tried fluoxetine, citalopram, venlafaxine, bupropion, vortioxetine, buspirone, mirtazapine, trazodone, aripiprazole, lithium. All our patients come to us with a long list of medicines that they've tried. And this patient also only had partial benefit from therapy. So this is the common theme for the referrals that we receive for TMS. People who really are looking for something to help them, and to date really have not had much success. So let me just back up and talk about a broad category of treatments that TMS falls into. I mentioned the name non-invasive brain stimulation. The other word for it is neuromodulation. And neuromodulation is the application of energy to the central nervous system for therapeutic benefit in psychiatric disorders. There are many different types of neuromodulation therapies that you can read about or learn about, ranging from cranial electrical stimulation, which is extremely gentle electrical current, to transcranial magnetic stimulation, which we'll talk about. Electroconvulsive therapy is a type of neuromodulation, and even vagal nerve stimulation and deep brain stimulation, which are invasive. These are all therapies in which energy, some type of either electrical or magnetic or even ultrasound energy is directed at the central nervous system to try to treat symptoms and improve disease. Our neuromodulation therapies today are very much in the mode of modern science. That is, they are evidence-based. They're done on a voluntary basis with informed consent. They're based on scientific principles that have been carefully elucidated and explored in the literature, and they're effective. What they're not are pseudoscience or inhumane or primitive or pointless or experimental. These are therapies that are meant to help people and are not meant to be punitive or create any kind of stigma. In fact, neuromodulation therapies go all the way back to the ancient civilizations. Ancient Greeks, ancient Romans were in fact using electrical therapies to treat illness even before the time of Christ. So for instance, an electric eel, otherwise known as a torpedo fish, would often be used to, their electrical currents could be used if you held them to your skin, you could have pain go away, you could have headaches go away, you could restore sort of vitality to a part of the body. So in fact, neuromodulation and non-invasive brain stimulation is some of the oldest treatments that we have in the world. It was in the 1800s that in Europe in particular, there was a concerted scientific effort to study this and to use this, to use brain stimulation, particularly electrical, because it was at that time in history that batteries were first invented and you could store an electrical charge. And so it was the Italians and the Germans and the French who tried at first to use electrical currents to see if they could treat mental illness. And this has now sort of culminated in what we have today with transcranial magnetic stimulation. TMS was first invented in 1984 by a man named Anthony Barker, who was a neuroscientist, and he wanted to use magnetic pulses to try to study how nerves conduct, how nerves sort of fire and carry a signal from one part of the body to the other. So he invented a device that was the first TMS machine. About 10 years later was when Alvaro Pascual-Leon and Mark George both had the idea, well, if you can cause nerves to be stimulated in your arm or your leg, why couldn't you apply that to the brain and actually stimulate the nerve cells in the brain? So they were the first to try to use TMS to treat depression. And then 10 years after that, in 2007, was when the FDA pivotal trials were performed in which TMS was actually proven to be effective and was FDA approved for the treatment of depression. Of course, that when something is FDA approved, that doesn't mean that it's going to be reimbursed by insurance companies, which is often the key linchpin in a treatment becoming more accessible and more available. So beginning in 2012, in the 20 teens was when we started to see significant reimbursement by insurance companies for TMS. So how does it work? TMS is the repeated induction of electric currents in the brain via an externally applied, rapidly changing magnetic field for the purposes of improving a symptom or disorder. And we hear a lot about magnets in different areas of medicine or different kinds of fields. And it's the key is that the magnetic field here is not a static magnetic field. It's not like taking a magnet, you know, like a kitchen magnet and holding it against your head and expecting it to have the same effect. The magnetic field has to quickly grow in strength and then quickly diminish in strength. And that's how, according to principles of physics, a magnetic field is actually able to induce an electrical current in anything that can conduct a current that falls within the field. And so you see the schematic of this figure of 8 coil being held over this person's brain. And you can see the red dotted lines of the magnetic field being generated when an electric current is run through that coil. So the magnetic field rises, and then when it's at its full strength, it passes through the skull and the scalp and actually envelops brain tissue. And because the brain tissue falls into the magnetic field and the brain tissue can conduct an electric current, neurons can do conduct electricity, that's what they're meant to do. You can induce an electric current in the brain by having this magnetic field, but it's applied from outside the head. And so that's how it's non-invasive. And that's why it's actually a sought after sort of solution. Rather than trying to send electricity into the brain from the outside through the skull and the scalp to the inside, you can use magnetic fields and they will pass invisibly through the skull and the scalp and influence the brain. So this is what the device looks like. This is our chair. I tend to call it a Barca lounger. It's very, very comfortable to sit in. Makes you want to fall asleep. I certainly would fall asleep very quickly in it when I sit in it. And you can see the little sort of tomahawk-looking thing that's black there. That's the coil, the figure of 8 coil that gets held against your head, against your scalp. And that's the TMS machine behind it, the white-looking boxes that generate the electric current that flows through that black hose to the coil there. What you don't see is that we have a TV screen that you can watch. So TMS is an outpatient procedure. There's no anesthesia. You're completely awake and alert and comfortable the whole time. So you can talk, you can read, you can listen to music, you can watch TV, you can meditate while the treatments are going on. And I had a little video there, but it's really sort of, I'm going to go ahead for the purposes of time. When the TMS stimulation is being delivered, it makes a noise, a clicking noise. So we give people earplugs so that it doesn't bother them. But this is what it's like to sit in the chair and to receive TMS treatment in our office. So the magnetic field is a very focused magnetic field. This slide is really sort of meant to convey to you that the reason why we use a figure of 8 coil there is because when you have the overlapping of the magnetic fields generated by each of those circles, it looks like a mountain peak in terms of the strength of the magnetic field. And so because it has a peak like that, we can actually be quite certain that when we hold the coil over a part of the head, it's the area of the brain that's directly underneath the coils, directly underneath the center of the figure of 8, that's receiving the maximum stimulation. This is what makes TMS actually very different than many other psychiatric treatments, than almost all psychiatric treatments, where you may have a powerful medicine or a powerful therapy or be using energy, but you don't actually know where it's going, and you don't actually know where it's having its primary effect. But with TMS, we know, because we know where that peak is of the magnetic field, we know where it's having its primary effect. So we can direct it to a part of the brain with a great deal of focality and specificity. So what does it do in the brain? This is a picture that is meant to depict what the depressed brain versus the non-depressed brain looks like. And what we see is that bright colors here represent metabolism, represent activity of the brain, and a depressed brain is significantly less active in very specific parts. In the frontal lobes and in the temporal lobes, that's where emotion regulation is primarily occurring. And as you can sort of see, and right is left and left is right in this picture, but you can see in the depressed brain, the right side of it, which is the left half of the brain, is quite dark even compared to the right side. And that's what we see, is that the left side of the brain, the left hemisphere, is underactive. And we want to use TMS to try to stimulate it to become more active and do more of what it's supposed to do. We pick a very specific spot where we do the stimulation. It's called the DLPFC. That stands for dorsolateral prefrontal cortex. That's a very specific spot in the frontal lobe that has to do with control of many different processes. It's considered one of the executive control spots of the brain. It connects to a lot of other structures, which I won't go into, but connects to deeper structures. For instance, the globus pallidus, the caudate nucleus, the thalamus. These all have a role in helping regulate emotions. But it's really one spot that connects to the DLPFC that we're really interested in, and that pertains to depression, and that's called the ACC. You can see that on the other side of the picture there, an arrow going from the DLPFC to the right to that area called the ACC, and the ACC is the anterior cingulate cortex. That is a key part of the brain that has to do with a number of things, including making decisions and motivation, and that's the part that we want to talk to with TMS. So the DLPFC is the part of the brain that's right there underneath if you hold your head like you just kind of banged your head on the cupboard or something and you hold it there, that's where the DLPFC is. And then the ACC is deep in the center behind your forehead. And the DLPFC is the window that we can talk to the brain and communicate with this key area, the ACC. And so we've actually done imaging studies, not at UNM, but this is an imaging study that looked at what happens when you do live TMS and then you scan someone before and after, and you see what part of the brain seems to be in particular kind of light up specifically from the TMS. And what you see on the right side of the picture is that area in the brain, which in the last slide was labeled the ACC. That's the part that is specifically activated by TMS. So we know that that's what it's doing in the brain. It's very difficult with any other psychiatric treatment to be able to say which part of the brain it's having its effect, but we can say this about TMS. This is one of the wonderful things about them, and one of the reasons why I am very interested in this technology. So when we perform TMS, and I've talked about these magnetic fields that rise and fall and create the electric current in the brain. We do it in a very specific way. And we deliver what are called pulses. The magnetic field rises and falls very quickly. It's a pulse that happens within a few milliseconds. And we deliver these pulses over and over. And over time, the delivery of the pulses seems to change the activity of the brain. And we take the brain, like I showed you in the picture, that's very dark, and we try to make it more activated. And the way that we give the pulses has a great deal to do with what the effect is on the brain. If you give pulses, magnetic pulses that happen 1 hertz or 1 time a second, so like that, that is actually going to slow the brain down. Slow pulses, you'll slow the brain down. But if you give it at 10 times a second, 10 hertz, like that, that actually excites the brain. So the speed that we give the pulses at has a significant effect on how the brain responds to the TMS. Other things that we pay attention to, how many pulses do you get in each treatment session? So in a treatment session, it typically lasts anywhere from 10 to 30 minutes. We typically deliver 1,800 to 3,000, sometimes 4,000, sometimes 5,000 pulses in that time. And that's been sort of established to be a very safe and effective number of pulses that you can receive in a session. We also pay attention to how many times do you come for treatments, the number of sessions. That has a significant effect on how effective TMS is. We also pay attention to when we deliver the pulses, we then take a break before we deliver more pulses, and how long is that break in between? that can have a significant effect. So we pay attention to all the different parameters that we use to deliver TMS. It's sort of like the dose of the medicine that you're getting. How many milligrams, how many times a day do you take it? How many days are you supposed to take it before you see an effect? All those same kinds of principles of a medication dose apply to TMS. We actually have very good evidence that when we deliver the different speeds of pulses, it causes different things to happen. So you see this brain on the right-hand side of the screen, and the top brain, or the top slice of the brain, the left and right, the left side is receiving sham and the right side is receiving active. There's no TMS being given in that slice, but in the middle slice, TMS is being given at 1 time a second to the right side of the brain. And you can sort of see that that right side of the brain is more green than the left side, which indicates that the activity, the metabolic activity of that side of the brain went down. It actually got colder. And that's what happens when you give TMS only 1 pulse a second. It actually slows the brain down. But then in the bottom slice, when you give it 20 times a second, that right side of the brain actually heats up. The metabolic activity actually increases. And so that's how we know, that's one of the most direct pieces of evidence that tells us that delivering TMS in a different way causes different effects. Like I said before, we pay attention to the number of sessions that you have, to the number of pulses that we give, and also, we can specify how powerful should the magnetic field be when it delivers a pulse. And what we've seen is that up to a point, up to the limit at which it's safe to do, the more magnetic energy we are able to deliver to the brain, the better the depression responds. So when you give more pulses in a session, that seems to have a more robust effect on depression. When you give more powerful magnetic fields up to the point that it's safe, that seems to also be better for depression. And when you do more sessions in a row, days in a row of TMS, that also seems to be better for depression. And so we pay attention to these trends, and we try to maximize on our UNM TMS service the way to achieve the best response for depression. What are the indications for TMS, or what are the key things that you have to have in order to be able to get TMS? First of all, you have to have major depressive disorder that's diagnosed and been around for 6 months. Again, most of our patients have had it for decades. You have to have tried at least 4 medicines. You have to have tried psychotherapy. You have to be able to attend the full course of treatments, which is at least 30 sessions. So 30 days of TMS. You have to have some folks who can check in with you and make sure and see how your mood is doing, and also continue to prescribe your medicines, your current psychiatric team. And then if there's a copay associated with psychiatric visits based on your insurance or your coverage, then that's just something that we check and make sure that our patients can afford the copays for the TMS. What are the contraindications for TMS? What would make it so that you can't get it? If your depression features anything like psychosis, or if you have bipolar disorder with mania, or if you have suicidality that's so severe that you're on the brink of hurting yourself, then TMS is not the right treatment. TMS happens at a pace that's about equivalent to starting on a new medicine. You hear about antidepressants, oh, you have to give them 2 to 4 to 6 weeks for it to work. Well, TMS also does not work right away. You need to give it a couple of weeks for it to start to have an effect. So if someone is really, really urgently needing help, TMS is usually not what's recommended. If you have any history of seizures, then TMS is not the right treatment for you. And the reason why is because when we deliver magnetic pulses to the brain, and we raise the activity level of the brain, that's exciting the neurons in the brain. And a seizure is what happens when your brain gets too excited. So if your brain tends to get too excited by things and easily has a seizure, there's a risk that TMS could cause something like that. And we definitely don't want that to happen. with our patients. So if you have any risk of epilepsy or seizures, that's a contraindication. If you have any metal or devices implanted in you, particularly in your head, neck, or chest, like a pacemaker or a cochlear implant, or any kind of metal that's embedded in your head, neck, or chest, that would be a contraindication for TMS. Getting TMS is just like getting an MRI. An MRI is a big, very strong magnetic field, and if there's anything metal in you, the metal that if it can conduct will respond to that magnetic field. And so, same thing with TMS. We don't want anything that can conduct a current that's metal inside you to fall within that magnetic field. If you have other conditions that neurologic conditions, that often means that we have to be very thoughtful about whether you can safely receive TMS or not. If you've failed TMS in the past, that usually means that you're not going to benefit from it again. Or if your life is so unstable or chaotic that you can't make it to the 30 treatments in a row, then TMS is probably not the right treatment for this time. I'm going to skim through this section here because it's not super important for our patients, but just to know that there is a dose, an individual dose that we find out for everyone when they get TMS. And in order to find the right dose, we figure out where on their head is the spot where right underneath it is the part of the brain that controls the hand. And when we find that part of your brain that controls your hand, we then put the TMS coil right on that spot and we give it a little pulse, and you can see your hand twitch, just like a little twitch, just like that. And it takes a certain amount of energy to make the nerves conduct all the way from your head down through your spine to your hand. That's called a motor evoked potential. It's a complete sort of path all the way from your brain to your hand. It's how your brain tells your hand to move. And we figure out how much energy does it take to actually see a twitch happen. And that's called your motor threshold. That is the dose of magnetic energy that your brain seems to need in order to conduct electricity. And when we know what that number is, we take 120% of it, and then we put the coil over the part of the brain that controls moods, the dorsolateral prefrontal cortex, like I mentioned before. So that's me sitting in the chair with the coil on my head. As you can see, I'm smiling. It's not an unpleasant experience. It does take some getting used to because the magnetic fields do feel like a woodpecker kind of tapping on your head. But once you get used to that, and everyone pretty much gets used to it pretty quickly, then the treatments go by no problem. What are the side effects of TMS? So common side effects include a headache after the treatments, because the TMS magnetic fields actually can cause some of the blood vessels in your scalp and in your head to expand or contract, in sort of a very slight way, and that can cause a mild headache. So we let people know you can take headache medicine if you need to. The woodpecker sensation on your head, that's sort of the scalp kind of face discomfort that people can experience, but they quickly get used to that. Some people don't like to sit still with their head, with the coil on it. So if you have neck or back pain, chronic neck or back pain, we just have to, work very hard to make sure that you're comfortable in the chair. The TMS, by stimulating the brain and getting it excited, it can affect your sleep. It can affect your level of anxiety. It can affect your concentration. Definitely not to the degree that other forms of brain stimulation might affect your attention or memory. This is just, if you sit there and have TMS, you may notice that afterward you kind of feel a little bit spacey, but everyone can drive home. Some people even go back to work. It's not something that you really have to worry about a long-lasting side effect. It's just something that we've observed in our patients, that their sleep, their anxiety, their energy levels, and even sometimes their focus can change. It does make a noise, like I said, so we give you earplugs. And then the most serious side effect is if you have metal inside you that we didn't know about. So we make sure to very carefully screen people to make sure that there's no chance that they have any embedded metal in them. Some people, even the tattoos of their eyebrows or their eyeliner tattoos may have metallic ink. So we ask about that just to make sure that there's no chance that there's any metal dust or particles that might be affected. And then the other most significant thing is, like I said, if you have epilepsy or risk of seizures, and then you get TMS, an overdose of TMS, that could lead to a seizure. So we make sure that, first of all, that we find the right dose and we never deliver overdoses. And second of all, that people who have epilepsy shouldn't receive treatment. The advantages of TMS over something like electroconvulsive therapy, like I said before, no anesthesia, there's no memory loss, there's no seizures involved, you're awake through the treatments, you're able to communicate, converse, watch TV, do whatever you like. The cognitive effects are minimal to none, and there's extremely low risk of seizures, which I've alluded to. These are the devices that we use, some of the pictures of the other ones, in addition to the one that I showed you in our clinic. The first one that came out in 2008 was the NeuroStar. Then in 2013, there was BrainsWay with the helmet or deep TMS. And then in 2015 was when several other companies were approved, MagStim and MagVenture. MagVenture is the device that we use at UNM. So how effective is it? And this is one of the questions that we get most often from our patients when they do an intake with us. You know, how much is this going to treat my depression? And so I start off with this slide to show people, particularly our patients who are, like I said, dealing with decades of depression. They've tried 10 to 15, sometimes 20 medicines. This is sort of the chances that your depression will get better with medication. And so this is the results from the STAR-D study that was done in 2006. In STAR-D, the people who were in this study have had depression, and they started with citalopram, the antidepressant, and a third of them got better. And then the people who didn't get better went on to the next step, level 2 of the study, where they added or switched to another agent, something like bupropion or sertraline or venlafaxine. And about another third of them got better. And so then, if you didn't get better, if you were still in that third that didn't get better, you then went to level 3 and you tried lithium or mirtazapine or nortriptyline. And as you can sort of see, by the time you get to level 3, your chances of going into remission, having no depression left, your chances are now lower, and they're actually in the kind of 15% range. So by the time you try your third medicine, there's a 15% chance that you'll get better. And then if you didn't get better in level 3 and you had to go to level 4 and try your fourth medicine, it was still no better. It was still only about 10 to 15% chance of getting out of depression. So, you know, the folks that we see, they've tried not just 4, they've tried like 10 medicines. And you can imagine what the rate of success will be by trying an 11th medicine. You know, we're looking at a very low rate of success. And this is what's so frustrating about depression, is that for the folks who wind up in level 3 and level 4, that's considered treatment-resistant depression, and it's very hard to get better. So the early studies of TMS, they showed that TMS was not like super effective. You only got maybe 5 or 6, you know, points on a depression scale improvement. It was barely significant, but that was the way that it was being done in 2008. Now, this slide shows you the same thing that slide on STAR-D showed you, which is that, you know, level 1, you have about a third, 33% chance. Level 2, about a 33% chance. Level 3, you only have about a 15% chance. And level 4, you only have about a 10 to 12% chance of getting better. And that was about what TMS in 2008 was able to do. It gave you about another 10 or 12% chance of getting better. However, we've made several refinements to the techniques that we use, and now what we see is in clinics that do TMS, these same patients who failed bunches of medicines, when they come in and they get treatment, they have, if you look at the black bars here, you see that they actually have a 37 to 40% chance of getting out of their depression completely. So that's a 40% chance compared to a 10 to 15% chance. The gray bars are those who respond to the treatment, which is 50% of your depression goes away. So you don't get completely out of depression, but you get 50% of the way there, which for a lot of people is really good. And with TMS, these gray bars show that there's a 60% chance that you'll get like halfway out of your depression. So we find, and I tell people who come to our service, 2/3 of our patients are going to have at least 50% improvement, if not 100% improvement. There's about a third that will have 100% improvement, but 2/3 are going to have at least 50% improvement. So when you put that on the graph here, the way that we do it, starting, using the techniques that were started in 2013, TMS is looking actually a lot better. It's looking like we have the same amount of success with TMS as people did, trying their very first antidepressant. And this is 3 to 4 times better rate of success than if you were just going to try another medicine. So that's what I tell people, is that with TMS, you have about you have a 3 times better chance of getting better than if you just tried another medicine. This is where TMS falls in the treatment spectrum. Usually people start with medications because it's easy to take a medicine. But by the time you failed 4 of them, now your TMS is that's when it becomes part of the treatment considerations by your treater. I want to tell you about something new that we've recently started doing and that the field has pretty much sort of adopted, and that's called Theta burst TMS. This is TMS, but done at sort of triple the rate. So when we talked about how many pulses to give in a session, I always said anywhere from 1,800 to 3,000, 4,000 pulses. And the way that we have to deliver them safely, 3,000 to 4,000 pulses takes about 25 to 30 minutes. With Theta burst, we discovered that instead of just 1 pulse, you can give 3 pulses at a time. And that's why they call it a burst. And then you give 5 bursts a second. And so now you're able to pack more pulses into a smaller period of time. It's just as safe. And now you've cut the time that you have to sit in the chair by half or even by 2/3. So people who come in and get Theta burst TMS, which is just changing the speed of the pulses, they're actually able to be done with their treatments in 10 minutes. So very quick time. People can come in, and usually they find that it takes them longer to find parking than to get the treatments themselves. And Theta burst TMS works just as well as regular TMS. There's a big study called the 3D study that came out in 2018 that showed this. So we use almost exclusively Theta burst at this point because, it's very time efficient and we want to be respectful of people's time. So it's another effective way of delivering TMS. How long does the effective TMS last? This is like the second most popular question that we get on our service. People want to know, is this going to cure my depression? Is it going to come back? How long will I have relief? And generally what I tell people is that you can expect 3 to 6 months of relief with TMS. It's not going to last forever. We don't change people's brains permanently, but it is going to give you several months at least of benefit so that you can do other things with your life that will also help you remain out of depression. One of the things that we would like to do, but we're not able to do yet, is to deliver maintenance TMS. So give, like, instead of 5 treatments a week, people coming in Monday through Friday, you can come in like once a week. And that may be enough to sort of help keep your mood going in a good way after you've had benefit from TMS. And so there have been several studies that showed that when you do maintenance TMS, that does help prolong the effects from when you had your first initial series. It's just that we're still waiting for insurance companies to wake up and get with the program and cover maintenance treatments. So just in the time that I have left, and very quickly, I'm just going to let you know about sort of the studies that we have going on at UNM. We have a lot of research in non-invasive brain stimulation. It's one of the things that we do well at UNM. So we have treatments, we have studies using TMS for looking at methamphetamine use disorder. We're looking at TMS for late life depression or depression that happens after age 60. We are looking at gentle electrical stimulation called transcranial direct current stimulation, or TDCS, whether we can use that in people who've had a head injury or a brain injury. And then we also have a large clinical trial where we're looking at a vagal nerve stimulation. And this is where you have a battery that's implanted just like a pacemaker, and it actually delivers an electrical current to your vagus nerve, and that seems to help keep depression away. So a lot of things going on. Be happy to sort of provide more information about those if people are interested. This is our team. We have technicians, we have nurses, we have data analysts to help deliver the treatments. It's really important with TMS to make sure that patients have a good experience with it. It's not just about coming in and getting magnetic fields applied to your brain, but it's about sort of the experience that you have as well that has a big effect on your mood. So we know now that we need to provide plenty of frame around this treatment. We need to make sure that people know what to expect. We make ourselves available for questions and issues that come up. We coach you through it. You know, when the woodpecker sensation, you're first dealing with it, we help adjust and the energy and provide you with, you know, just to make it sort of more comfortable for you. And then we also know that when you come in and you see the same people every day for like 5 days a week, 6 weeks, that's kind of intense. And like, you get to know us really well and we get to know you really well. And we have to acknowledge that for some people, that's a pretty intense experience. They're not used to seeing people that often. And so we have to make sure that we're helping people to understand, to work with us, to know what it's like to work with a team that intensively. This is just some statistics on who comes in and gets treatment at UNM. Most people are in their 50s. The average age is 55. Their average depression score on a scale, the PHQ-9, is 17 out of 27, which means that it's moderately severe depression. 2/3 of our patients are female, and headaches and increased anxiety are some of the common side effects that people report. This is what the first 37 patients, what their depression scores look like from when they started at week 0 to when they ended at week 6. You can see that most of them got better. There are a few people whose depression scores, you know, mildly went up, but again, our statistics on our service correspond with what I showed you in the slide before, where about 2/3 of people have at least half their depression go away. If you look at this graph, this is a little bit sort of difficult to sort of see, but if you compare how we did in year 1 to how we did in year 2, this is on the y-axis. This shows you sort of what percent of people's depression got better. And the middle line going across is the 50% line. So you can see in year 1 that most of the dots fell under the 50% line. So we were still perfecting our technique, training our team, getting them really sort of efficient and effective with TMS. And you can see in year 2 that actually most patients had more than 50% improvement. So we were really proud of that, and showed us that we were heading in the right direction. And that sort of brings me to the end of my talk. I just want to let you know kind of the take-home points that TMS is safe, well-tolerated form of brain stimulation that's effective for treatment-resistant depression, that it works by inducing electric currents in the brain and some of those brain areas that I showed you using magnetic fields according to physics, and that it's available for those with depression who've tried multiple medications and therapy and can safely receive it. And it's something that we're very interested to do more of, and are studying it to sort of see how we can apply it more broadly. So at this point, yeah, I'm happy to answer any questions that folks may have.
Thank you very much, Davin. Excellent presentation. I'd like to throw it open to the audience if there are questions. Also, Jess, if any questions were typed in from Facebook, if you could take a look at that and relay those, that would be good. And of
Yeah, I have a
course,
question.
yes, go ahead.
So when you're talking about the rate of delivery, it reminded me of brain waves, and you have brain waves at different hertz as well. Like the gamma is like at 40 hertz, and you have a range of brain waves that go from what, half a hertz or higher, I think. And so has there been any correlation between the work you're doing and what brain waves are stimulated and how those interactions work?
That's such a great question, and thank you for asking that. So there is a great deal of work looking at brain waves and the oscillations of the neurons in the brain. Like you said, they occur in these sort of well-known kind of frequency bands, and TMS does not necessarily have a clear effect on any one of those. It really sort of depends on kind of what frequency band you look at, under what conditions. And so under certain conditions, you may see that, for instance, alpha waves, which are 8 to 12 cycles a second in the frontal lobes, may increase after TMS. Or you may find that theta waves, when you're doing a memory task, theta waves coming from the center of the brain seem to increase in their amplitude. So we don't have yet sort of a firm grasp on how brain waves respond to TMS. What is another really interesting form or line of research, though, is can we deliver TMS at the speed of those brain waves and almost sort of like go in sync with your brain waves, and does that make it more effective? And depending on sort of what frequency it's being delivered at. And so it's that is a really interesting line of research. I think there are a handful of studies that show that when you sync the brain stimulation with your native brain waves, that you actually do get sort of pretty robust effects. But that's super cutting edge right now.
Thank you. Additional questions from our group here on Zoom?
We had a chat question. Can you hear me?
Yeah, I've got that. I was going to ask.
That was,
Go
does
ahead.
the patient have to stop medications during the treatment?
Another great question. So no, the patient does not need to stop their medicines. And in fact, we encourage them not to stop. We tell them and recommend them that they continue their normal antidepressant regimen. And even if in the middle of treatment, you know, they have some issues with their medicines, they're allowed to change the doses of their medicines. So they should have their medications managed by their psychiatric provider or prescriber the way they normally would. We don't recommend that people stop their medicines or decrease their medicines during treatment, because what we've noticed is that just in the cases of the people who did that, they tended to not do as well as the folks who continued their medicines.
Yes, Betty. Are you on mute, Betty?
If somebody just wanted to have TMS as opposed to taking medication, and they were like willing to pay for it out of pocket or whatever, are you able to do that, or is there some medical reason why you wouldn't?
That's a great question, and there's you absolutely can get TMS and pay for it out of pocket and not have to wait for the predominantly insurance industry imposed restrictions on trying for medicines and trying psychotherapy and such. You could make it be your first treatment that you try for your depression if you were willing to not use insurance.
Okay, good.
Is there anybody doing a trial looking at TMS as a first line of treatment instead of collecting data on the third line of treatment to see what the response would be in that case?
The earlier studies in the TMS literature did look at that. They looked at people, they recruited people who had only failed, say, like one medicine, and then recruited them, as opposed to the people who failed 4 or more. And what they've seen in studies from the early in the field, the early in the literature, is that the TMS that was delivered for people who were early in their depression and tried fewer medicines actually worked better. Now, so you could say that might indicate that, oh, you should use TMS early in your depression and not late in your depression after you've tried a bunch of medicines. And I'm not quite sure if I can conclude that. It could be that, the people who have only tried 1 or 2 medicines and then got TMS, they may have been sort of perhaps a little bit more likely to get out of depression on their own. But I will say that in general, for all psychiatric treatments, if you are less treatment resistant, if you've tried fewer treatments, then you're more likely to have success with something like this.
Let me ask a different question. Another treatment that you didn't mention that's sort of a third line treatment for difficult cases is ketamine. What's the comparison between TMS and ketamine for those treatment-resistant patients?
Another great question. Everyone comes in asking about ketamine in addition to TMS. So ketamine and TMS and even ECT are all sort of considered at about the same time in people's kind of depression history. And so the patients who get ketamine or S-ketamine, which is the inhaled version of it in our clinic, tend to be very similar to the patients who get TMS. It really sort of comes down to which is sort of more palatable for the person. Would they rather kind of use the ketamine or the S-ketamine, or would they rather go with TMS? S-ketamine has not been around as long, so we don't have as much data. We have 30 years of TMS data to look at, but we only have a few years of ketamine and S-ketamine to look at. And some people just don't necessarily want to tolerate the somewhat dissociative effects of ketamine and S-ketamine. So it really kind of depends on just what treatment is more palatable to you. But and I would say that TMS probably has a longer track record that we can look at as opposed to S-ketamine.
Thank you. Not hearing any other questions, I have one more, and that is, can you tell us any more about the mechanism whereby the TMS interacts with the nerve cells? Is it just a heating effect in the local region? Is it an electrical connection? Does it affect predominantly synapses or axons or even the nerve cell body?
Mm-hmm. Yeah, great question. And I left some slides out in this talk that I give. I give the same type of talk to other doctors and psychiatrists and such. And the best understanding that we have of how TMS treats depression, I gave a sort of a fairly rudimentary explanation, which is that we want to kind of excite certain areas that are underactive. Well, that's not the whole story. The more complicated story, and the one that we're still trying to sort of sort out, is that there's a relationship between networks in the brain that are responsible for all the different functions of the brain. So there's a network that is responsible for allowing you to focus. There's a network that's responsible for telling you when you're in danger or when there's something really big or important about to happen. And then there's a network called the default mode network that sort of allows you to be introspective and kind of look inward and sort of daydream. And and the interactions between this attention network, this salience or importance network, and this default mode network, those relationships are what mental health and flexible sort of healthy functioning of the brain are about. Those networks can be very flexible in terms of their functioning. In depression, those networks get stuck in like certain relationships to each other. And with using TMS, we seem to be able to talk to several of those networks and cause them to become uncoupled, so that you have less of a sort of a, you're stuck in a rut with these networks kind of just, operating kind of in a very sort of pathologic way. So for instance, you might expect that when you're depressed and all you can think about is how bad you feel, and you just sit around the house all day, that default mode network is pretty active. And then, your motivational network or your salience network is pretty underactive. And they may be sort of tied together in a certain way. And then when you stimulate the brain with TMS, you seem to uncouple those networks so that they're not connected to each other so strongly. Mm-hmm. So that is a very sort of metaphorical way of kind of talking about what we think is going on with these brain networks. It's, on the one hand, yes, we are heating up one area of the brain, and that sort of is an easy story to tell. The more complicated story is that these networks are very intertwined and interconnected, and when we stimulate with TMS, the relationships of those networks to each other changes, and people seem to get better.
Thank you.
I do have another question, Tom.
Oh, excellent.
It's, how do you get referrals? Another from the chat.
Yeah, so if you Google UNM TMS, you'll get our webpage that has the referral phone number, and you can call. And usually what we need is just information from your psychiatric provider about the treatments that you've tried and your medical history, and that allows us to make sure that you can qualify to get TMS. So UNM, just Google UNM TMS.
Excellent.
Yeah, I guess I have another question, a follow-up. So you talked about heating the brain up. So what is the fuel for heating the brain up, and how does that fuel get sustained after treatment?
Great question. You guys are pushing me in terms of my ability to explain these concepts, so I appreciate that. When if you took a neuron and you put it in a petri dish, a single neuron or a string of neurons in a petri dish, and you hold the TMS coil over those neurons in the petri dish, and you stimulate it with 1 hertz a second or one pulse a second, what you see is that those neurons, they may have sort of a basal firing rate, or a rate of firing that is just inherent to its behavior. And when you give 1 hertz TMS to it, you see that basal firing rate slow down. And so the firing rate of neurons is affected by TMS. When you give it the 10 hertz excitatory TMS, the basal rate increases. So just the sort of the inherent sort of preferred firing rate, and we think that probably has to do with not just the TMS causing the neurons to fire themselves, because it goes above sort of the amount of energy needed to cause an action potential, but it actually probably changes the neuronal membrane sort of excitability or its polarization, so that you can actually get it to fire more easily. So that's probably at a very cellular level what TMS can do. Now, when you get, but TMS is, the magnetic fields are much larger than that, and you're hitting, hundreds of thousands or millions of neurons with each pulse. So we get these neurons to fire in a fashion, or cause them to fire in a fashion that sort of changes their inherent kind of activity as an ensemble of neurons. And that's sort of the inter-network connection that I was referring to earlier, where if you cause these neurons to sort of fire at different rates, or to oscillate at different rates, or to have connections with the other networks such that they're not kind of so yoked together, but they kind of become kind of more dissociated, then that's sort of where we see kind of the symptomatology start to decrease. And so it's not simply a matter of just inputting energy and the neurons fire more, and so therefore you're able to concentrate better. It's actually it then becomes sort of a much more kind of complex discussion about kind of the strength of connections between the neurons. And so that's unfortunately the best that I can do in talking about what we know about TMS.
So in the mathematical theory of neural networks, they talk about Hebbian mechanisms. So if a neuron connection is fired over and over again, it changes the threshold and it makes it stronger.
Right.
So is that the kind of thing you think that's happening?
I believe that there is a Hebbian process at work, because what we see is after, if we stimulated and as long as the pulses are happening, your mood is better. And as soon as the pulses stop, your mood is back to depressed. Then there's been no neuroplasticity and there's been no change in sort of connections that lasts beyond the stimulation. And I think the reason why TMS benefits last, 3 to 6 months is because there has been sort of Hebbian neuroplasticity that's been triggered, such that, there's been changes in the strengths of connections between neurons, changes in their sort of how receptive they are to other ensembles of neurons, stimulating them or causing them to fire. So there's very much sort of a neuroplastic process that is most likely Hebbian at some level, which is, neurons that fire together, wire together, So thank you for bringing that up. Yes, there's absolutely that. I would say that is going on.
Excellent. Betty.
Okay, I just have not as technical question as Jim just asked.
Thank you.
Are there other people besides UNM who are doing TMS, other providers?
Yes, so I'm aware of at least 3 other, if not 4 other providers in the state who are doing TMS.
Okay. Cool.
Thank you. I think with that, I'd like to thank our speaker. It was a fascinating talk, and obviously for families struggling with a member with mental illness, knowing that, research is pushing ahead and more options are showing up is really very hopeful. So thank you, Dr. Quinn, for your time and your material.